Hey everybody, it's Karen Anderson here with our week in review with Aortic Hope. I'm just remembering I didn't turn the volume down on my phone. Okay, so what is a week in review? It's a time where we review all of the weekly posts that we've put up on our website and other social media platforms, allowing all of you to have a moment to chat with us here. Kind of give your opinion, share your thoughts, blah, blah, blah. But we don't only go live for a week in review. We go live when, and I say this every week, we go live when we interview people, when we have some brave souls who want to talk about their survivor story, thus giving you an opportunity to ask questions of them. So there's a lot of different reasons that we go live. And if you want to know about them, other than checking out the events tab on our website, right over there, you can just click the bell. First of all, you have to click like, because you just have to. Second of all, you have to click subscribe and then hit the bell so you're notified every time that we go live. And then you'll have these opportunities to interact with us. So we're going to take it away, Sam. Why Sam? I don't know. Sounded like a great name to use in that moment, Joshua. Hey, I heard I'm very trainable. Tell me, say Joshua, and I retain information.
3 years later.
Not,
Can you check your mic settings to make sure that your mic is the mic that you're micing on?
oh, do I maybe have my mic somehow? No, my mic is plugged in.
I'm just curious. It sounds a
And
little echoey.
let's see. We're gonna check it.
That's not where you need to go at all. You
Do,
need to
do,
be
do.
into something completely different.
Oh,
Just check
everybody's gonna see what I'm
Teams.
completely in. I'm in. Well, let me check the volume. Oh, maybe something's coming apart.
Oh, something
It's
just
spun around.
changed.
Well, I have to
There you
spin it
go. That's
closer.
better. That's better.
Maybe that's what it was.
Christina says hi.
Hey, Christina, having a little technical issue.
I
Hello,
just said it's
Christina.
better. Stop futzing with it. Get to
I
work,
didn't touch it.
lady. Get to work.
I'm off. Time to work. Let's go into when our Monday was. It was Medical Monday. Let's talk all about it. Watchful waiting. I've not heard this term before. I've only heard watch and wait. I know that word full just made a difference, but watchful waiting is actually a phrase that's used in the community, but what does it exactly mean? So watchful waiting for an aortic aneurysm is actually a strategy that involves regular monitoring of the size and shape of the aneurysm without any immediate treatment. It is usually recommended for small or medium aneurysms that do not cause any symptoms and are not growing quickly. Let's just call it what it really is. It's called annoying because that's what watchful waiting is. And we're going to talk about some of those real emotions that come with this. Watchful waiting, the concept, the idea behind the two words is that it aims to reduce the risk of a rupture or a dissection, which are, as we know, life-threatening complications of an aortic aneurysm. Rupture is a complete tear through the aortic wall. Let's not get these confused. A lot of people in the community tend to get the word dissection confused with rupture. A rupture is a complete hole through the wall. A dissection happens in one of the inner layers, and we're going to talk about the layers of the aorta in just a little bit. So, and again, a dissection is a partial tear that creates a false lumen or a false channel which the blood is flowing, but it's leading to nowhere because you have a true lumen, the section that actually feeds all of your organ, the oxygenated blood. Watchful rating might actually include periodic image tests. We know we have to have those monitoring, those diagnostic tests. They would be a CT scan or an MRI. So hear that word or. CT to some people in the community is the end all be all, only thing that's going to give you an accurate measurement. That's not true. An MRI is also another great tool in measuring the size and the shape of your aneurysm. And the main differences between the two would be that a CT scan is a lot quicker than an MRI because that might take about 45 minutes and a CT takes about 5. But the other main two differences that would be considered your negatives would be CT involves radiation. Now, for a hefty amount of people in the population, they're allergic to that contrast and they need pre-medication. So by the time you're pre-medicated, that takes an hour, you might as well just get yourself in queue for an MRI. Typically, CTs are given in the ER, MRIs have to be scheduled. So there's a few nuances, but again, watchful waiting includes having these types of tests done or an ultrasound / echo, they're the same, or even a TEE, transesophageal echocardiogram. And basically, they're checking for changes in the aneurysm. It also might include watchful waiting, might also include medication. And these medications are used to control and or lower your blood pressure, your cholesterol levels, your heart rate. A variety of things will occur when you take these medications that hopefully will help reduce the speed in which this aneurysm may grow. Additionally, there could be lifestyle changes, and that would definitely be quit smoking, smoking cessation. That is a definite must happen. Obviously, we always want to be eating healthier foods. Whether you have aortic disease or not, eating healthy foods and having a healthier diet would always be recommended. And exercising regularly. That's a whole other conversation because, really, for people in this community, what does that actually mean? And we talk about that constantly. And as a basic, it means taking a walk. It just means walking. That's not something you're necessarily going to have to clear with your physician. Can I walk? Because walking is something that we do every single day to get from A to B, unless you have a different type of impairment that keeps you from walking. But doing all of these things will actually just help improve the health of your aorta, actually your overall health in general. And when you're improving the health of the aorta, it actually helps to prevent any further damage. Watchful waiting does not mean ignoring an aneurysm. And I think for a lot of people, once they're told, all right, you have a mild dilation or you have a mild aneurysm, you know, come back and I'll see you in 5 years, that would lead me to say, for me, in my opinion, and I'm not a doctor, if I know that I have a family member who's had aortic disease or something that even appears as such, I would want to make sure that I'm monitored probably sooner and that all of the lifestyle changes we just spoke about were definitely in place, that I knew my blood pressure was under control, et cetera. But it is very important to report any changes that you might feel. Now, typically aneurysms are asymptomatic. They're not going to have symptoms unless they're really large. So if they're really large and they're in the ascending thoracic in that area, you might, especially if it's in the arch, if it's larger, you might be able to feel some sensations when you're swallowing. I have heard that. If it's in the abdominal area, though that threshold is a lot larger before intervention, you might be able to feel pulsating. You might be able to feel your pulse in your abdomen. Some people have even been able to known to be able to see it. So they see that abdomen pulsating. But typically, there's not going to be, I'm having shortness of breath because of an aneurysm. However, if the aneurysm is in the root or in the ascending, you possibly could be pulling and tugging on your valve. Now, changes in the valve, that could lead to shortness of breath. So having something that's asymptomatic, it's really critical that you maintain some form of observation over your aneurysm. But if you feel changes and you cannot, we're always asked, what would a dissection feel like? And for the majority of the people, they say this ripping and tearing sensation going down your body in half. But there's plenty of people that just don't feel anything or they just feel off. So you know your body. You have to make the decision if something feels truly off to reach out to your physician, to have that conversation, maybe even have it ahead of time so you already know what to be on the lookout for. And there's nothing wrong with going to the ER with going to the ER basically to make sure that everything is okay and seek emergency care, especially if you do feel an onset, a rapid onset of some type of pain, dizziness, if you lose consciousness, that type of thing, you got to go to the ER. So lightheadedness, et cetera. But plan that out with your physician ahead of time. Find out in what scenario, while I'm doing watchful waiting, would I consider this an emergency? Because many people in the community feel sharp pains in their chest. They come and they go. And a lot of times, if you change your position, you might find that you had some residual gas or you had reflux. Sometimes it could be something, but it's hard to know when it's an emergency. So this is a very personal scenario. No two people are the same. Please have that conversation with your physician. Find out as much information as you can about your situation, exercise, healthy eating, blood pressure numbers, heart rate control. When is it an emergency? When you're in the middle of watchful waiting. Okay? That's watchful waiting and Medical Monday.
Hi, Velda.
Okay. Hey, Velda. Thanks for joining us. Velda, I feel like Velda must live in an igloo just because it's so cold where we are and she's so far
It
north
is.
that I pictured Velda
It's completely
like gloves.
Canadian cold out here right now.
It's like it's Alaskan cold, I feel. It's
Yeah,
North Pole. It's
North
North
Pole.
Pole. It's North Pole, and I need a palm tree. All right, let's move on to topic Tuesday. All right, guys, this is a great post again from our third year med student, Adam. And he, right off the bat, just basically said, uh, those of us that are in this polar
No,
vortex,
no, no, no. You will read
yeah,
all of Adam's words. That is your job. Don't go skipping down to the third paragraph. Begin again.
well, then I have to use, and I'm going to have to like change my voice.
You can do the best.
Hi,
I know you
beloved
can.
friends, colleagues, and friends at Aortic Hope. Now, I hope you have been doing well since the last time we talked. For our members reading this in the Northeast, I hope you're bundling up during the blizzard, although there was really not much of a blizzard. For our conversation today, Adam wants to review aortic anatomy. This is when having aortic dissection, the patient guide would be handy. You could read along with us. Some of you have already downloaded this guide, and others of you have received a hard copy, hopefully from your physician. If not, you have had one sent to your home. But if you go to pages 13 and 14, this is a really great graphic of cross section of the aorta. So let's take a look at a couple things that you're going to see on these pages. This is an awesome graphic showing the human body and basically giving you a layout of the entire aorta. So as you see here, we have the aorta. I feel like we're recording this again for the audible. We're gonna not start here because I'm in charge, and we're gonna start here coming out of the heart. See right here, this is the ascending. We are ascending. We are going up. This section in and of itself is the ascending aorta in the thoracic aortic area. Thoracic meaning your chest. Other things in the thoracic area would be your lungs. Okay, so when people talk about thoracic, they're talking about your chest, just above your diaphragm. After the ascending aorta, you come around the bend of the arch. Remember, we described this kind of like a candy cane. So now we're coming up into the arch. Now, what we don't have noted in this particular graphic is there are vessels that branch off of the arch, and that's going to lead to like your carotids. These are the vessels that take that oxygenated rich blood and head it up towards your head. Remember, the entire aorta feeds your entire body with all of this oxygen rich blood. Coming down, it is descending. And when we talk about dissections, Dr. Ben Udelman said it great. A type A is an ascending A. A type B is descending. So again, anything that's after the arch is going to be your descending or type B dissection. So this is descending. You can still be in the thoracic area and have a descending. So you can have what's called a thoracic aortic aneurysm in the descending area. Okay, just because someone says thoracic doesn't mean ascending. It could be on this side of the heart, which is behind the heart, and that's descending. Let's move on into some more areas that I may mispronounce. Okay, just forewarning you. All right, this section here, which is now past the diaphragm, is called the suprarenal abdominal aorta. And the reason is because this is above your renal arteries, which take you to your kidneys. These are your kidneys right over here. Just south of the kidneys would be your infrarenal aorta. Okay, those are what those areas are. And then we are into your truly into your abdominal aortic area, and it splits into iliacs. Your iliacs are what are feeding your legs. Okay, you're gonna have a left iliac and a right iliac. I'm gonna have a little bit of a sneeze. Here it comes. Okay,
One
just
more.
one today. Sorry, just one. God, the other day I had 7. All right, just one. All right, so if you remember, the aorta encompasses our entire body and includes an arch, as we showed before, right? We've got the arch. And it includes ascending aortic area that comes up out of the heart, descending aortic zone, that's anything after the arch heading down, descending, traveling all the way down the abdomen and splitting into the 2 large arteries that supply our legs. Those are the femoral arteries. Okay, let's take a look at the cool cross section here of the aorta. This would be looking in the tube of the aorta. This is it. We're looking down. And what you see here is this aorta, this like incredible major highway of our body, the lifeline of our body, only has 3 layers. That's it. And according to surgeons working with these layers when they're doing surgery, they've described it as trying to suture wet, like tissue, like when you blow your nose, like Kleenex. That's like the consistency. It's not like it's this very fibrous, hard thing that you're working with. So very delicate. And what you have is the innermost layer, that's the intima, the innermost layer right here. Okay. The middle layer is called the media, and the outer layer is the adventitia. So typically, when you have a dissection, you're cutting through one of those layers. If you have a rupture, it's gone through all three, right? So this was a cross-section analysis of the aorta that shows that it's actually composed of the three beautiful layers, as Adam describes it, the intima or inner, the media or middle, and the adventitia or the outside layer. Another way that doctors actually look at the aorta um, is the aorta and standardize its anatomy is to classify it into zones. This is the first time I've actually really paid attention or heard the terminology putting it into zones. So Adam does include a great link to a graphic here about these zones. So let's take a look at these zones a little bit and listen to me really struggle to pronounce some of these words. All right, let's start off here. We have the aortic root. So this is right here at the valve of your heart. Okay, so just picture a heart right in this area. All right, so we've gone beyond the root. We know we are in the ascending, right? Because that's the part that comes out. And so this ascending area, take zone 0 is the ascending area that leads you to this delineation line of the innominate artery. This is the innominate artery. I did not know that's had its own artery. Then you move on to zone 1, and that is the innominate artery to the left common carotid, or LCC. Again, that's the second of the three branches that come off of the arch leading into your head. Then there's a small area here, zone 2, that takes you from that LCC to the left subclavian artery, or the LSA. Okay. Again, these are zones that the physicians, the surgeons, I'm assuming, are using to really get a good sense of when they need to create a graft, right? Do they need to create a graft that includes zone 0, 1, and 2? Well, that would mean innominate artery, your left carotid and your left subclavian, right? Because you're in zone 0, 1, and 2. All right, moving on to 3. Zone 3 is the first 2 centimeters distal to the left subclavian artery. That's all that is, just 2 centimeters worth. Zone 4 is truly in the descending artery right now. And zone 4 is actually zone 3 to the mid descending aorta. I'm not sure what T6 means. I don't understand that part. All right, zone 5. This says it's the mid descending aorta to the celiac. Okay. So right before the celiac, this is through the diaphragm and a little bit under the diaphragm. That is zone 5. Zone 6 is at the celiac artery to the superior mesenteric artery, SMA. So that's what you've got here for zone 6. Okay. These all sound like arteries that feed into your abdominal area. I don't know. I could be very wrong. No, I'm probably very wrong. More like diaphragm. I would be interested to know. I really don't know. Maybe Josh, you can pop and find out, where does the celiac artery lead to, and where does the superior mesenteric artery? I'm still thinking it's someplace in that area. Could have gotten that from Grey's Anatomy. I'm not really sure. But zone 8 is your renal arteries. That's your renal to infrarenal abdominal aorta. That's your zone 8. So zone 9 is your infrarenal abdominal aorta. That is post or south of your renal arteries. You had your suprarenal artery area was just above the beginning of that artery, below that black line. Okay. Zone 10. Now remember, we're in the abdominal area here. Zone 10 is your common iliac arteries. All right. And zone 11 is the external iliac arteries.
All
I
right,
don't know what the difference
let's
of
go
that
up
is.
again.
Yep.
The celiac artery provides oxygenated blood to the foregut, blood to the stomach, liver, spleen.
Right. And you know why I thought that? Because when you think about celiac disease, it's got to be in that area, right?
I
Okay,
guess.
but it also takes it to the spleen. And what does the superior mesenteric?
That's going to take me a bit to type that.
Okay, you find that. But the key here is having this standardized classification system actually helps your providers directly pinpoint where the aneurysms or the dissections, where they are and what they involve. Some high yield zones to remember are the following. Zone one, which we're going to talk about this in a minute. So, okay, so zone one, which we already mentioned, this is a high yield zone. The innominate artery, also known as the brachiocephalic trunk, which supplies blood to the right side of your brain and the right arm, and the left common carotid artery, which supplies blood to the left side of your brain. This is high yield. So this is high volume blood. This is a key critical area. If you end up having a dissection in this area, this is going to be definitely a very uh, emergent situation, high yield. Zone two is the left subclavian artery, which gives off several arteries that supply your actual chest wall, your left arm, and your left brain, another high yield area. So, zone one and two, right here, pretty important areas, high yield areas that are in the arch. Okay. I'm not a physician, I'm just reading the information here. Okay. So, uh, let's just talk about what some of these areas are here at the very top portion of your aorta. Again, you've got your ascending aorta here with your root down here. Brachiocephalic trunk that splits into one of your common carotid arteries and subclavian right here. Then you have artery that goes right to common carotid and another one that goes to subclavian. And then now that you've moved past the arch, you're completely into descending aorta land. Okay. Collectively, the innominate artery, left common carotid artery, and left subclavian arteries constitute the great vessels of the aorta. So all of those that branch off of that arch are the great vessels of the aorta. From zone 3 onwards, we're officially in the descending aorta area. Zone 6 and zone 7, your celiac trunk and your SMA, they provide blood to the major organs in your abdomen, including your stomach, liver, and intestines, which we were just looking up. See, it came after. All right. This is talking all about the celiac and the superior mesenteric, which is midgut or foregut. So I think this looks like this is probably like this 4-week-old embryo. Look, I was about to say it was a CT scan. So this is what it looks like in your 4-week-old embryo, where not everything is formed. Here it is in an adult. These are the different areas and where they're found. It's so interesting when you see the difference based upon gestational age and as an adult, where these areas would be found. So here in an embryo, you've got a much shortened aorta and your main branches are like pretty much the bulk of that aorta right there in the middle. Whereas you've got these 3 areas are spread out completely into the descending area. Okay, zone 8 is those renal vessels. They supply blood to your kidneys. And zone 10, the aorta splits into the common iliac arteries, which supply blood to your groin, your pelvis, your lower extremities, your reproductive organs, and your legs. And that's a lot, but very interesting because we just kind of talk every day about the aorta just being this big, massive vessel. But it is important to a lot of people to know details. It's definitely important to your physicians to understand the zones and where you've had issues. So if you get back a CT or an MRI, or even an echo that goes through zones, now you know what the zones are and you know what the zones mean. And so Adam goes on to say that I hope you have an incredible week. Stay warm and stay happy when you have time, try looking at that beautiful graphic and see how much you can memorize, because he's probably going to quiz you. Cover the labels with your hands and see how much you get right. And so after all, the more you know aorta, the more you can think aorta. Oh my God, that's brilliant, Adam. The more you know aorta, the more you think aorta. And that's the key. We need to think aorta. So that was our
He does a
topic
killer job.
Tuesday. He loves what he does.
He does a killer job. Also, Chef Rob jumped into the chat to say hi.
Hey, Chef Rob.
And then I said hi, Chef. And then Velda goes, hi, Rob. And I go, Rob. Velda says hi.
All right. Well, that's our Tuesday. Very interesting stuff. Let us move on to our Thursday. What happened there? Where did
I
the
don't
rest of
know.
my stuff go?
Hit F11.
Just hit it. Therapeutic Thursday, everybody. All right. As we told you, every year we try to come up with a theme. We've been doing this for a while. Let's see if we can recant our theme. So 2020 was movement for movement. 21 was emotional health. 22 was collaboration. 23 was helping us help you be all you can be in 23. And 24 is receive more in 24. So here is some of the ways that you can receive more from Aortic Hope or just yourselves in 2024. So if you're in the position to schedule elective surgery and find yourself asking a lot of questions like, what should I bring to the hospital? What will recovery actually look like or be like? Just any of those types of questions, especially when you have an opportunity to have an elective event, then you need to take a look at our pre and post surgical suggestions. We have a list. Here's the link to the list. Let's get into this list. The fun thing about this list is it was completely created by members of the community sharing things from their own personal experiences. So there's really nothing that's massively scientific to this. This is just what's worked for other people and tips and tricks of when you have an opportunity to schedule something. Here's what you might want to think about. So it's strongly suggested that you have a loved one with you. Now we're in this post COVID and yet COVID numbers ticking up world. You really do want to talk to the hospital before you have your scheduled surgery. Find out who can come with you. Can they spend the night? Because things are beginning to change a little bit depending where you live and how your numbers are with COVID, RSV, and flu in your hospitals. Okay. But assuming that everything is fine, you want to have somebody with you before your surgery, during, and after, because you need an extra set of ears. We're so nervous. We have so many things going on in our mind that a lot of us tend to miss stuff, right? It's going to go right over our head. So even if it's not a family member, bring a friend. Bring a friend, have them ask questions. Always somebody else is going to have another question to ask. It's just a scary, it's an emotional time. They're going to help you retain the answers anyway and maybe can take notes for you. Another person that cares about you being present, really, they, as I said, they're going to have other questions. They can help you have your questions be addressed there. And they're also a nice emotional support person. Make a list of questions ahead of time that you might have. Here's some things that you might want to ask. So, how many hours do you think the surgery is going to last? This is important, not for you, because you're going to be asleep. It's important for your loved ones, for your friends and family that are waiting. They want to have a general sense because if you tell somebody it's 5 hours and the doctor walks out at 4.5, people get really scared. They think they're about to receive bad news, and it's just going to be jarring until they see a smile on the doctor's face. If you tell somebody this surgery is going to take 5 hours and we're in hour 7, they're going to be very frantic, wondering what complication has happened. So let's get a realistic expectation of time frame. I think a surgeon is always going to overshoot rather than under promise. And it'll always be great to see somebody earlier than anticipated, right? They'll have an idea and if they should leave to get a cup of coffee, whatever the case is, but ask that question. How long do you think it's going to take? How long do you think you're going to have to be in the hospital? Like, what's the recovery looking like? Am I in the hospital? Am I going to rehab? Am I just going to a step down unit? How long am I going to be in this facility or a facility? That's important to know. What exactly is the procedure? Are you repairing an aneurysm and doing a valve? Are you going in to repair an aneurysm and it could be valve sparing? But what if you need to repair the valve? Let's talk about valve options ahead of time because once you're under, they're going to go to your next of kin to ask, I need to now fix their valve. What kind of valve do they want? So you need to have all of these things thought of, decisions made ahead of time. In the event there's some completely different um, procedure that needs to take place. And obviously talk about the risks, the pros, the cons, the whole 9 yards. Okay. When should you wake up? What does waking up look like? Am I going to have a breathing tube in? Am I going to know? Everybody wants to know, am I going to know if I'm on a ventilator? And, everybody's experience is different. I don't think I realized I was on a vent, but I thought that I was Aquaman and I thought I can breathe or not breathe. But if I don't breathe, then I breathe. Yeah, I didn't know. I didn't understand. I was just being woken up enough. And then I was told to cough, and then it just came out. It's not one of those things that I can even tell you if it hurt coming out. My throat hurt afterwards. While the vent was in, evidently, I asked for a piece of paper and I was writing questions like, am I alive? Am I breathing? Am I okay? I have absolutely not even one thought about that. I don't recall any of it. And they didn't save the paper for me, but I was told by my father that I was writing, scribbling questions. So, will you be aware? Maybe. Will you really remember it as being horrible? Probably not, but there's no guarantees. I think the goal is to have everybody not really remember until they start waking you up so that you can breathe and they can see that you're trying to breathe more on your own. And at the end of the day, there's nothing you can do about it. It's not going to scar you, I don't think, for the rest of your life. I would hope not. It's part of the process. If it is, it might not be. You have to ask. Catheter. Will there be a catheter in place? How long will a urinary catheter stay in place? That's important to know too. What are we talking IVs? If you care, we people who had an emergency dissection, we didn't get a chance to ask. We just woke up, lit up like a Christmas tree. So if I have to, and I will have to have additional surgery, I want to know: am I going to have a line in my neck? I didn't like that line in my neck. Not that I'm asking because I have a choice. I like to be prepared. I want to know: is my arms going to be taped to boards and then strapped down to the bed when I wake up? Because that's how I woke up with my emergency. I'm just somebody who likes to know. So if you like to know, that's a good thing to know. I am a big person on wanting to know about a pain management plan. I do not do well with pain. And it's not that I'm a baby and it's not that I have a low tolerance. I've had experiences where I've been in a lot of pain, and when you push the button, nobody's coming because it's nurse change time. It's shift change. And when your pain meds fully wear off, you are now chasing pain. And that can be um, just horribly painful and not necessary. So if I'm told, well, this is the pain management, this is what we're going to give you before you wake up, maybe you have a patient controlled apparatus you can push, what have you. I like to just know what the plan is when it comes to pain management. All right, number 3, if you're someone who tends to become anxious, discuss this with your physician because there is a chance they can give you a little something, something beforehand, kind of make you feel a little bit more comfortable, take the edge off. It might make the whole thing a lot more easier to tolerate. We've already discussed this. See if they'll allow a family member with you in the hospital. I know now for most part, with something scheduled, they'll let them come back once you've been have all your lines in you and you're situated while you're waiting, which is just nerve wracking. They'll let somebody stay with you till they will you back. That is pretty standard now. It's the same with you afterwards, that each hospital system is changing their rules a little bit. All right. 5, suggestions on what to pack. If it were up to me, I would tell you pack nothing but a charger. Because anything you bring with you, you have to now schlep home. It's a lot. And if you end up in the ICU, less is best. Less is best. But some people have suggested if you have an idea how long you're going to be there, you may want to have your own pajamas. These pajamas where our butts hang out the back are not necessarily the greatest. They're not necessarily IV friendly. You have to untie them and then they're hanging off of you. They fall off. Um, I'm a less is best, but if you want to bring your own pajamas, of course you certainly can. I'm also would be nervous that maybe I started bleeding from one of my lines, so I don't want to mess anything up. But that's, they're soft. They remind you of home. If you think it'll make you feel better, then you should do it. If you do not want to wear their treaded socks, although sometimes these different colored treaded socks mean something different, like a potential fall risk, uh, bring your own. But if you're going to bring your own socks, make sure they have the little rubber treads because the last thing you need when you start walking around is to slip. That is not what you want.
Oh,
Slippers, if you're going, what?
let me break in there. So during the Aorta hangout, we had a new lady
Yeah,
jump in and tell us about having her post dissection troubles. I think she's about a month and a half out,
yeah.
and she was getting so cabin fever so badly, and there's snow everywhere. that she's out
Oh,
walking on snowshoes. I'm like
on
and
snowshoes.
I'm like, "Do not fall."
Do not fall. And like, that's a whole other conversation on what that super cold weather could be doing to her blood pressure and her vessels. But okay, snowshoes. Well, getting back to slippers, don't get slippers that you slip your feet into that, like kind of flip and flop behind your heels. Put on an actual shoe like a moccasin because you don't want to, take that step forward and your slipper kind of slips off and now you just don't want to trip. Sometimes using what they give you and not your own is better. It's you're protected underneath of them because it's their devices. You want to just wear them in your room when you're sitting on a chair because it reminds you of home, great. But my suggestion would be less is best. Just use their socks. Women, we get this question a lot, because sometimes when you have your aneurysm fixed, you're going to need open heart surgery. It is not every time, but it is sometimes. Same thing with valve replacement. Bras. A lot of times, don't worry about it. But ask this question ahead of time. Some hospitals, when you wake up, you're in a bra that they give you that clasps in the front. And yes, it doesn't matter what size you are, they have bras that fit all people with clasps in the front, which is pretty amazing. If you're a woman, you know what I'm talking about. But sometimes they provide them to you. And if they do, you might want to ask to take home an extra one in whatever size they put you in because it's going to be your best friend. You cannot reach behind yourself to clasp or unclasp. I'm a spinning around to the front, so as many other women, not to give you too much information, but even that's challenging after you've had open heart surgery. So to be able to clasp right in the front is so much better. So if you're comfortable in what they put you in, ask to take home another one. It's worth spending the money and it's less than what you're going to spend in the store. And you already have it, so it's convenient.
That's like the first time I've ever heard buying anything in a hospital is less than buying it from the store.
Well, it's also the convenience. It's there. It's like, trust me when I say you're in no frame of mind to think, oh, I love this. Let me focus on my phone and order one from Amazon Prime so it's here tomorrow. You can't even see the screen. You're so, it's like, it's not going to happen. There is no playing on phones. You can barely keep your eyes open long enough to say, hi, thanks for visiting, and then you fall back to sleep. So, unless you have a family member, which would be great, ask the nurse, what is she wearing? Write it down, go to Amazon, try to find it, hope it's the exact medical grade, same thing, and then order it. And then it arrives. It's so much more convenient because by the time you're ready to discharge, it's already in your bag. Really, trust me.
Diane
Trust me.
says, "Let them
I
girls
say
be
the truth.
free."
Some people try that too, girlfriend, and it's painful. It really can be painful if it's free. It could tug on your incision. So that's something to think about too. But everybody's different. So it might be easier for you if you let them fly free, or it might be easier if you hoist them. Depends on if you're a hoisting kind of person. What am I saying? Okay, next. Some people suggest bringing essential oils. Essential oils work. They're scientifically proven to work. So, lavender, chamomile, rose, frankincense, these are all oils that will reduce stress and anxiety. They produce a calming effect. That's why spas use these smells a lot. So, eucalyptus, menthol, peppermint, they're all the kind of things that wake you up. So if you want something that's going to be calming, chamomile, lavender, rose, frankincense, consider bringing some of those oils. And they're great if you're in a room by yourself. Please do not think about using them if you're sharing a room with somebody because they may be very allergic. And if there's an essential oil, let's say that is melon based, there are people that are allergic to melon so bad that if it ends up a vapor in the air, they could go into anaphylactic shock. So there's a lot to think about here. If you're in a room by yourself, go for it. And we're going to get into one of those essential oils in a minute. Okay. Some hospitals are actually giving lavender. They're giving you these kits that have an eye mask, earplugs, a little bit of essential oil because they want you to try to sleep because we know we can't sleep in hospitals. It's just noisy and beepy and lights and whatever. All right. Should you bring toiletries? Some people say you should. If you like your Sensodyne toothpaste, you should bring it. You should bring your own toothbrush. You could bring an electric razor. You can bring shampoo, conditioner. I didn't even know my room had a shower. I never made it to my bathroom in my room. Some people don't. So, in other surgeries I've had, I ended up getting to a place where I took a shower. Do you think I really cared about my own shampoo, conditioner, and body wash? Getting that sponge bath was the best thing in the world. I didn't have to do anything, I didn't have to take care of any of that. So again, it depends on how you are with surgery. If after a day or two and you're feeling up to it and you want your family member or loved one to bring them because it makes you feel better, it's all about what's going to make you feel better. I couldn't have cared less about what kind of toothpaste I was using. And quite frankly, I used the toothbrush she gave me. Why? It was something less that I didn't have to take home with me. Less is best. Okay. Same thing with deodorant. Now, I will say with deodorant, hospitals tend to give roll on deodorant and they are very wet and you're stuck flapping around for a while just trying to dry your armpits. So, that I would probably bring my own thing because I like a stick and I
I'm
don't like
allergic to
using
those.
what?
I'm allergic to those.
You're allergic to roll on or stick?
The like the roll-on bar stuff.
Okay, that's two totally different things.
Yeah, I can only use whatever like the cream stuff is for deodorant.
Yeah, I like a thick, just the stick, the solid. I like a
No, no, I'm
solid. I
allergic
don't
to
like
that.
liquid.
Yeah.
You're allergic to solid. Okay.
And,
So,
and
yeah.
the
So
liquid is what I'm saying. Both of those.
you like a spray.
No, 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 no. I don't mind a spray, but it's like there's
Okay.
a cream one that men can have.
Interesting. That sounds like
Yeah,
Lumi. Well, you know what? In your case, you would want to bring something with you.
I wouldn't use any of them. I'm gonna stink.
Okay. All right. But familiar tastes, familiar smells, familiar sensations might bring you joy and might make you happy. Uh, so when it comes to toiletries, consider what you want to bring that might make you happy, but you still have to pack it up and take it home or just throw it away. That's on you, right? Definitely pack your cell phone and your charger because you may want to text people and tell everybody you're okay, or you may just be like, the hell with it, I don't care. You may want to have it in case you want to call a loved one, but then usually hospitals have it's called a landline. Not many people remember those, but you can use their landline, their phones in the hospital room, and they don't charge you anymore to connect them. I can't believe there was a day where they used to charge you to use their cell phone, their cell phone, their telephone. Um, I wouldn't even worry about an iPad because you're not going to have enough energy to actually play Candy Crush or something like that or to read. Just allow yourself this time to just disconnect and just be in recovery. And of course, remember anything you take to the hospital, you have to take home, except a visitor. Visitors are great if it's somebody that you like, if it's like one of the top 10 humans you actually enjoy. But they can make you feel better. They can make you feel like they're lightening things up, lightening up the mood a little bit. Just make sure they check in with you or your loved one, the person you've designated, because it might not be a good time. Maybe you aren't sleeping, maybe you are napping, but visitors could be really good for the soul. And don't, as we talked about pain earlier, don't try to don't try to tough out pain. You don't want to be chasing pain. So if you're in too much pain, that can create a trickle down effect. You might end up having higher blood pressure. You could end up having higher heart rate. So really stay ahead of pain. Feel comfortable pushing a PCA if you're given one. That is a patient controlled analgesia. It's a button. You hold it, you push it, it's going to give you pain medication. You could push it 10 times in a row. It's not going to give you 10 different dosages. It knows when you're allowed to actually have that medication administered. So, but you push it if it's time. If you don't remember, just push it and see if you get anything. And if you are uncomfortable, push the call button and let your nurse know. Maybe you need breakthrough pain medication control too. So don't be afraid unless you have like a predisposed issue to an addiction. A narcotic is not a terrible thing to take in the beginning. What can happen if you're on it long term is you can become constipated and you will need to have a stool softener because you don't want to have to bear down when going to the bathroom. So that is something a doctor is going to talk to you about as well. My general thought is, though, as well as the community member who contributed this, is you don't want to chase pain. Okay. And if you're in the ICU or the SICU, it's usually 2-to-1 ratio, two patients, one nurse. So you should be able to reach out and someone will respond to you. Okay. Get up, sit, and walk when cleared and told to do so. Do it as often as they tell you you can. So as soon as they say, If you would like to walk, let us know. We'll come in and we'll walk with you. Try to do it as much as you can. Even if you feel tired, and all you can do that minute is just get up and walk to the chair in your room. The more you move, the more you turn on your systems, the more you get your intestines stimulated, the sooner they can give you food, the more you're keeping that blood flowing, the more you're using your heart, the more you're into recovery mode, the closer you are to going home. So, and your doctor says walk and move and sit, then you need to do what your doctor is saying. And if you can't, you need to speak up and let somebody know why. Okay, somebody had said take a picture of you when you're in the hospital. Excuse me. Examples of pictures could be when you're on a respirator, could be right before you are wheeled out. Some people, some loved ones want to do that because they're fearful they may not see them again. It could be taking a picture of you when you're sitting in a chair. It could be when you're taking your first few steps. Some of the beneficial reasons to take pictures during that beginning stage is because that gives you it's almost a documented visual diary, so that as you continue down your road of recovery, when you sit there, as many do, and they get to this point when they're like, I am not getting better, this is taking so long. When you look back and you see how bad things looked when you were just sitting in a chair, you will realize, oh, wait a minute. No, I'm actually doing much better than I was a week ago. And to that point, don't look at recovery in terms of um, days or minutes or hours. You have to look at it, give yourself, I know people say it's a process, so day at a time. Yes, one day at a time, but don't actually go to look at how am I progressing until it's been at least a week or two. That's when you're going to see remarkable difference. Remarkable difference. But pictures do help. They do help, and you can always toss them if you want. It's not anything that has to be publicly displayed. People do find it therapeutic to look back and to see. I know I have pictures. I didn't tell my husband to take pictures, but he took one in the initial hospital when I was first diagnosed with this dissection. He took one when I had just had the breathing tube taken out. And he took one the first time my angel of a nurse washed my hair and put it in a bun. And when I just had the nasal cannula, the oxygen tube in. And the difference is amazing. It's amazing. And it was a hard picture. It's not a pleasant looking picture, the one where I'm lit up like a Christmas tree. But I look so different. And I noticed it right after the end of the first week when I finally got home. And I remember looking at myself and thinking I looked like a monster. And then I went back and looked at that and I was like, oh my God, I'm alive and I have color. Look at what I look like there. I was bloated. I had all these IV lines in me. I had just been through the ringer, and it really helped me with my perspective on where I was in recovery. Okay, moving on. Ask a close friend or a family member to provide updates for you. If you're on Facebook, Instagram, wherever it may be, uh, people are going to be concerned. Even in a scheduled elective surgery, they're going to be concerned. This is very tough for them as well. You cannot discount that you are going through some fear and a lot of emotions in a watchful waiting scenario, but so are they. So are they. And one of the easiest ways to do it is to create a caringbridge.org account. So in CaringBridge, you can put photos, you can put updates, you can put links to your favorite charity like Aortic Hope, right? And people can make donations, people can leave comments, people can leave well wishes and cheer you on through CaringBridge to not clog up Facebook. The other bonus is if it's not in Facebook, it's not going to come up on your history and your memories. If you wanted to, then put it in Facebook. But for some people, it's too hard emotionally. So CaringBridge is the way to go. Okay. And then you direct people that you really feel close to, that you feel you want to share this information with, direct them to go there. When your friends and your family members come to visit, tell them to bring cards, because you might be in and out of sleep, and this way they can keep themselves busy and not just watch TV. They can, you know what I mean? They can play a little game, checkers, whatever the case may be. Because surgery can take a lot of hours. I know they're going to be on edge, but especially when you're in recovery and you're in your room, this might help them pass the time away. Ask questions about your surgery when you're nearing the time when you might be discharged. You're going to have to ask them over and over and over again sometimes. because you might not have great short-term memory initially due to the surgery and due to medications. You might not even remember why you're in the hospital to begin with. That is okay. It's all normal. So to any of your loved ones, let them know this will be normal. Many people report not even remembering what got them to be there in the first place, or remember what the doctor said, or remember who visited. No, it does not mean you had a stroke. It means that you are recovering from something that was huge, that was big. Um, and it's okay to cry. A lot of people have a lot of emotions, especially after open heart surgery, more so men than women. I don't know that there's been a scientific study about this, but if you find your loved one is crying at a kitten food commercial because there's kittens, that's normal. Okay. Crying because you feel like you could have died is normal. Just crying because you're tired, you're crying because you're not sleeping well in the bed, you're crying because you're taking all these medications, and everything is different. It's normal. It will subside. It could take a few weeks, but it will subside. And if you find that it's creating issues with sleeping, or your eating disturbance, or nightmares, or what have you, please mention it to your physician, because now you might be in a situation where you might benefit from a social worker or a therapist to come and talk to you. All right, remember we talked about aromatherapy. So tried and true, peppermint. Bring peppermint with you. And I say this because when you've had a catheter, sometimes smelling peppermint will actually help you go to the bathroom. So after that catheter comes out and your bladder has been basically paralyzed during surgery, when you have uh, a smell of peppermint, it relaxes the muscles. And I know this personally because when I had a C-section and they took the catheter out, I couldn't go. And I was actually begging to be recathed. And then she dropped a couple oils of peppermint oil, and like a couple drops of peppermint oil, and I went right away. So every time I have scheduled surgery, I bring an Altoid, or I bring Crest toothpaste because it's really nice and minty, and I smell it, and then I go right to the bathroom. I'm telling you, it works. It may not work for everybody, but it works for the majority of people. Okay, here's some more great tips. Potassium. Sometimes our levels of potassium or magnesium, they get wonky and they go off the rails when we have surgery. If you need potassium, it burns in the IV. I don't know how else to tell you. It burns. And hopefully you have a really good empathetic skilled nurse, and they recognize you're going to be there for a few days. And so they will mix it up well and have saline going at the same time, and they'll slow down the speed, and the ratio will be different. But when it starts to burn, if it starts to burn, hit the button right away. You can take potassium via pill or liquid. It's disgusting in liquid. Pill could make your tummy feel jacked up. But there's ways to take it in the IV that will minimize the impact to your veins. Just have a conversation with your nurse. If it happens to you, I'm not ever saying any of this is guaranteed to happen. These tips are based on other people's experiences, okay? Nurses are incredible, incredible. But it doesn't mean you're going to mesh with all of them. And there is nothing wrong that if you just feel there's a personality conflict, ask for the charge nurse and ask if you can just not have that nurse again. Just ask, can I just have somebody else assigned to my room moving forward for however long I'm here? Or right now in the immediate, I need somebody else. We're just, there's a miss. There's a miss. We're not aligned. I'd feel better. It's perfectly okay. It's within your right, and they will make that accommodation for you. You do not need the extra stress. You are recovering. Okay. Find out from your physician if he or she is going to try to prescribe cardiac rehab. If you're having your valve replaced, typically it's not an issue because the valve's part of the heart. Cardiac rehab happens when things happen to your heart. A lot of times people who have aneurysms or dissections, they're not granted cardiac rehab for some reason from their insurance. But if you are not granted cardiac rehab and your physician wanted you to have cardiac rehab, ask about getting a script for physical therapy. If you get a good DPT, doctor of physical therapy, they will learn about the ranges for your heart rate, your blood pressure goals from your physician. They will report those findings on when you eventually start to move your body around. They're also going to report what you feel your exertion rate was, how tired you were, sensations you were feeling. So it's different because you don't have a EKG monitor on you while you're moving your body, but the reporting structure would still be the same. And this way you'll learn diaphragmatic breathing, ways to feel more confident about sitting upright and about stretching. They'll take you through all of that. So don't, if they say no to rehab, still make it a yes. There's other things that you can do. Sometimes you can come out of surgery and survivors have reported having pain in their shoulders. This is normal. It's due to positioning. It should get better with stretching when you are allowed to stretch, depending on if you had open heart surgery or not. There's a lot of variables here. Again, this is all just suggestions based off of other people's experiences. Let's talk about mental health. As described earlier, some survivors have discussed feeling depressed, blue, whatever after surgery. This is, again, very normal. When people are having nightmares or they're having triggers that make them hear things that aren't happening, smell, taste, feel things that aren't happening, that now is typically symptoms of potential post traumatic stress. Um, your brain gets affected when it has major trauma or major surgery, and it needs to be cared for because the brain basically takes a back seat as your body is being worked on. So don't hesitate reaching out to a licensed clinical social worker or just a social worker for some kind of support or individual therapy. There are many different individuals out there. Only LCSWCs, I believe, are specialized in providing direct, specific treatment options for people with post traumatic stress, including but not limited to EMDR or eye movement desensitization and reprocessing. There's also support groups. We don't know of many that exist anymore that are brick and mortar where you go face to face. But Aortic Hope is the only organization really that is offering virtual support groups. It's a very strong community led by other patients, other caregivers, gives you an opportunity to really ask questions, hear about other people's experiences, and on occasion, we do have guest speakers, thoracic surgeon, cardiologist, other mental health uh, clinicians will come out, will answer questions, give you some of their time, and then they'll leave so you can have that private environment to kind of share what you're feeling and you're thinking. Now, if you want an environment that's not very serious, but this is still after you've had all of these, this procedure done, then consider joining Aortic Hope's Hangout. You need to sign up the same way, gives you an opportunity to have a much more lighthearted experience with people who have had similar things to you, but maybe we're not talking about the heavy topics and conversations. So that is the very extensive pre and post suggestions list. We would love to hear from you if you have things that we did not think about adding on this. You can always email us at info@aortichope.org and just say pre-post suggestions list, and we'll be sure to add your idea to this list. That's a lot to talk about there, Joshua.
That's always a big one. That's always a big
It's
one.
a
How
big
often
one.
do we add to that?
Usually we get it like one or two a couple times a year
Mm,
because this is pretty extensive list. You know,
yeah.
it's every time I read it, I'm like, yeah, I don't think I can think of anything else beyond that. All right, moving on to Feel Good Friday because I got a really, really, really busy schedule after this. So we're like time crunch, whip cracking. Feel Good Friday, but I love this topic. And thank you to so many of you who paid attention to this post because we have significantly increased the number of people who have signed up for Hope Mail. This is what it is. Hope Mail started with this organization back in 2017. 4 people signed up and wanted Hope Mail. They wanted a crocheted pillow that I knitted. And then we did a GoFundMe. This is before we were a nonprofit, and we raised money. We got all these little tchotchkes, like a pill case holder and a flashlight, and a couple people signed up and they said they wanted something in acknowledgement of the aortiversary. And now we have over 300 people that have signed up. So once a year, during a month that you choose as your aortiversary month, and I know some of you have had 2, 3 surgeries, pick one. You only get to have 1 month of tchotchkes. During the month of your aortiversary, we will send to you a few tokens of our appreciation and acknowledgement about your aortiversary. We just want you to know we're cheering you on. And I am telling you, there are people in this community, plenty of you who are on year 1, but so many that are on year 20, year 30, and more. And those get me so, and look, all of your years get me jazzed, but the really long years at coming up on year 9 for myself in just a 7 days, It's amazing. It's amazing to me. So whatever is on your list today, go sign up for Hope Mail because it's free. It's our gift to you, our way of saying we hear you, we see you, we're excited for you, and thank you for being part of the community. And thank you for your support. Feel Good Friday. Hope Mail.
And also,
All
don't
right.
forget, if you have
Forget.
moved, please
If you
send that
Thank you.
change of address in to Tammy at
Yes.
aortichope.org.
Yes. Yeah, if you've moved, we don't know unless you tell us you moved. So if you have signed up and you have not gotten any Hope Mail, it's because we don't know that something happened to your address. So just shoot us an email like Josh said, Tammy, Tammy, at aortichope.org, and let her know, hey, please change my address for my Hope Mail, and we'll take care of it right away. Okay? And usually everything's mailed out by the 15th of the month. So just in case, your date was the 2nd and you haven't gotten anything, that's why. Okay. Let's go and let's see. Where are we? We are on Aortic Hope reading resources by the community for the community. Okay. Are you looking for a great book to read? Because I know I am. I just finished, well, I'm almost finished reading Matthew Perry's book. It's just gut wrenching, but I really, really like it. And to let you know the kind of reading I do, I'm then moving on to Britney Spears. No, no judgment, no judgment. Thank you. It's the books I like. All right. But you need to check out these books because so many of these books are written, they're all written by community members, for community members, by patients for patients. That's our hashtag. First up, Aortic Dissection, the Patient Guide. I would be remiss if I did not mention this book to you. You can get a downloaded copy for free right now. There's links on the front page of our website. Just click the button and you'll download it. This gives you the A to Z of everything that has to do with an aortic dissection. And we're excited to tell you that the Spanish version will be here soon. Downloadable version of the Spanish book, and we're going to be taking pre-orders from physicians to be able to provide the hard copy to their patients. Please tell your physicians about this because they can order a box of 25 books and we will ship that to them for free. We want no financial barrier. We want no barrier between people and their opportunity to receive a copy of this book. So check that out for sure. That was written by patients for patients. Okay. If you read it, please click the link and fill out the survey. It's very helpful for us because guess what? We're beginning to work on our second guide. Zoop. That's all I'm going to say about that. All right, Dissected, Healing with Poetry, My Journey with 2 Aortic Dissections. This is the second edition. The cover looks a little different, but God, that's an awesome cover. I love it. I think it's very cool. So Maria Trinidad Herrera had her first aortic dissection surgery in 2009. The fears and questions became overwhelming. The difficulty with the diagnosis and the lack of knowledge of some of the medical professionals worked against her. What could have been addressed with a stent or observation, if found on time, led to a complicated and dangerous emergency open heart surgery that forever changed her life. The psychological traumas after surgery became a daunting chore and led her to finding a healing path. Poetry became her path and fortified her spirit in her most vulnerable moments. You are not alone. We read some of this on a live event that's on our YouTube channel here that you can look up. And her poetry is really great. It's really great. And we look forward to working with Maria in the very near future on a few other projects here with Aorticopa. Check out that book there. All right. Everyday Sinner, Miracles from an an Unconditional God by A.G. Helms or Andrea Garrett Helms. I laid there helplessly looking at my beautiful husband's sobbing face as the surgeon said, "You need to decide who is your priority. Your wife or your child. Life is such an amazing, wonderful journey, but at times it's like a really badly paved road. You're traveling along and bam. Hello, whiplash. Hello, insurance claim. Hello, Route 44 half and half tea with lemon and the good ice you've waited all day for. That's dumped all over the floor. I love how she says that. Our lives over the past 2 years, and it's been longer now, have been more like a bumpy jungle safari trail in an old Jeep with 3 partially deflated tires. God and we beat infertility. God saved our baby and God saved me, a walking, talking, breathing hot mess. He had mercy on an everyday sinner like me. There are 4 cases in the world of pregnant women with type A and type B aortic dissections with an aortic aneurysm. 2 of those 4 resulted in both the mother and the child perishing. People say we are walking miracles, but we say our God is a God of miracles. It took me 2 years to write this book emotionally and physically. It holds the most personal details of our journey, and I pray that it gives you hope. I pray that it encourages you to speak to your mountain, whatever it may be, with boldness and confidence. I pray that it brings you closer to Jesus Christ. I pray that you turn every last page feeling loved because, friend, you are so very, very loved. And that is from A.G. Helms. Okay, next up, How My Ordinary Became Extraordinary by Terry Benson. How My Ordinary Became Extraordinary invites you inside my harrowing journey through one of the worst heart conditions possible. After waking up to find my life fractured by my condition, I fought to reassemble the pieces into a normal life. But when climbing the stairs felt like hiking Mount Everest and brushing my teeth became an actual accomplishment, it didn't take long to feel discouraged. This is the true story of my recovery from an aortic dissection and the people and mindsets that pulled me through it. Whether you're standing atop your personal mountain or still scaling the cliffs, this book is for you. All right, here's another book by a community member called Life After Death, a true story of surviving an aortic aneurysm and dissection by Robert Fisher. Imagine rising on a normal day, unaware that you have a rare, deadly, underlying medical condition. Without warning, an excruciating pain crosses your chest. You barely make it from your living room to the operating room, but your body somehow manages to hang on, narrowly surviving what most do not. But surviving the initial incident is only the beginning as complications arise. This is the true story of Robert, who at age 55 experienced one of the most traumatic events in life, an aortic aneurysm and dissection. With less than a 5% chance of survival, Robert was one of the lucky ones. You may remember hearing about aortic dissections. It was what killed TV sitcom actor John Ritter in 2003 at age 54. Trying to make sense of his near-death incident, Robert spent many hours talking through what had happened to him and his wife, Carol. Those talks soon turned into journaling about all that he had to cope with. That journaling evolved into the writing of this book, as Robert wishes to bring awareness about this deadly condition. For those dealing with an aortic dissection or for those interested in what life is like after surviving such a terrifying ordeal, this book may offer you some insight. And finally, Miracle Man Beating the Odds, Cheating Death by Scott Pribble. Do you know anyone facing or has faced major surgery, illness, disease, or other life changing personal financial situations? Does that person need hope, inspiration, spiritual grace, and the sheer will to keep going? Do you know people who need to lose weight quickly yet permanently with minimal exercise? The author, Scott Pribble, survived an internal injury that is 90 to 95% fatal. In this book, he describes his 7-year rehabilitation and comeback. Pribble also describes how he lost 50 pounds in 2 months. If you are someone who has written a book or poetry or anything, please let us know. We would love to share your information. I just love that there's so many community members who have shared their journey, their personal experiences, and I look forward to seeing more. I know there's a couple of you writing some stuff right now, and I can't wait to see it.
Oh, it would be so good if Chef Rob would put together a nice heart health and aortic healthy cookbook,
We got to do it. I'm sure he
right?
would. I'm
We
sure he
should.
would.
We should stop letting him go
We would.
on like 9-month vacations. You know what I mean?
I agree. I agree. I would love it if Ryan Rodimer would put together Genetics 101, but we'll see. That could
Genetics.
very well happen.
Ryan
Telling
would
you.
kill it. He's awesome.
I know he would. All right, let's wrap this up because I got places to be and people to see. All right, events. We've got a lot of events, and I'm still working on finalizing our February events. So, what is today? I don't even know. Today is the 22nd. Oh my gosh, it's the 22nd. All right, this week, coming up tomorrow on the 23rd, we have our Ask a Doctor with Dr. Prakash. Now, that will take place on Facebook. However, simulcast, Terry Cook, our board member here at Aortic Coat, will be going live with me here. That's why you click the bell so that you're notified. And we're going to be hanging out, talking about a bunch of different stuff and sharing the questions that are posed on Facebook with all of you here on YouTube and answering them. We're going to share what the doctor's answers are as well. So we're kind of hoping to tag team and take advantage of 2 platforms at the same time. The 25th, we have our Aorta Hangout this week, as always, on Thursdays with Chef Rob and his wife, Mindy, hanging out. It's exactly as it sounds. We already discussed that. Fill out the registration form for our Survivor Series once. You'll be notified when the hangout is. And on Thursday, it's another Qigong event with community member and survivor Kevin Songer. So come and move with us and have fun with us Thursday night. Then we have our last week in review for the month of January with Tammy Warner and an incredible live event on the 30th with Dougherty, Chella, Keene, and Associates, as we are going to be discussing navigating the Social Security disability, uh, process, because it's so incredibly daunting. But we're going to take your questions. We're going to go through everything. It's one of our most popular live events. And if you click that bell and you click subscribe, you're going to get notified. You'll be able to join and tune in with all of us. And of course, we have our last virtual support group meeting, as we do the last Wednesday of every month at 7 p.m. Eastern. And that is going to take place in a private setting. Again, you need to fill out the registration form once and you'll be notified about our support group meeting. Thank you to who is all here?
Oh my God. Also,
Christy?
Marche jumped in to say hi. We had
Marche,
Christine, Velda, Chef
Christine,
Rob,
Velda,
Diane.
Rob,
Marche said that
Diane,
she
Marche.
loves the book, Aortic Dissection, the Patient Guide.
Thank
I
you.
asked her if she got a hard copy. She said yes. During last
Thank
week's
you.
Aorta Hangout, we had like 4 people hold their books up. It was so good.
That's
So good.
awesome.
I
That's
know.
awesome. That's so great. Well, I can't wait to talk even more on tomorrow night about our seatbelt covers and the 2 new ones we have as offering. So, and if you guys see things out there that you think other members in the community would really benefit from, please let us know and we will look right into that. But thank you, everyone. Christine, Velda, Rob, Diane, Marche. Thank you, Joshua. We appreciate you all being here. And Tammy will be your host next week, next Monday, 3 p.m. Eastern, not 4 p.m. Today was a fluke. And we'll see you next week. Don't forget, click like, click subscribe, click the bell, and we'll see you soon. Thank you so much. Take care.